Welcome to Parkinson's Awareness Month, which runs for the month of April, and welcome to a new venture for Parkinson's WA. We here in Parkinson's WA sadly had to postpone our newly diagnosed seminar, so we decided to celebrate the month of April in a slightly different way. And I'm about to launch a series of short educational videos which you can freely access through a link provided by the Parkinson's WA office. For those of you who don't know me, my name is Janet McLeod, and I have been with Parkinson's WA for quite some time. And my current role is clinical nurse manager for the nursing team. So today, what I'd like to do is take you through a short journey on what is Parkinson's, where we think it comes from, and how it is diagnosed. Parkinson's, as you may be aware, is a common progressive neurological condition. It is very common, although not as common as many other conditions, but among the group of neurological conditions, it is the second most common. We guesstimate that there are approximately 100,000 people Australia-wide living with the condition. And in the group of neurological conditions, it comes in as number 2, second only to dementia in all its forms. While people may think that Parkinson's is a condition of older people, it's important to know that there is a huge number of people diagnosed as what we call young onset Parkinson's. And strictly, according to research, the criteria for being a young onset person is diagnosed between the years of 21 and 40. So 1 in 7 of the 32 people guesstimated to be diagnosed each day in Australia actually fits the criteria of young onset. Having said that, of course, we do know that aging is a huge risk factor for developing Parkinson's. Parkinson's can affect all aspects of life. In spite of it being classified as a neurological condition and also a movement disorder, we know that there is nothing in life that potentially this condition cannot affect. And I must say it's important to know that this condition is not life-ending. It is not a terminal condition, but it may be a life-altering condition. And under normal circumstances, while we know it's progressive, we commonly regard it as a slowly progressive condition. So we nursing team, we have patients who have been living with Parkinson's for up to over 40 years. So it is quite a slow, in most cases, quite a slow, gradual progression. And the good news is that it can have a treatment. We now have many effective treatments, although we still are searching for that elusive cure. So just to recap, this is a progressive condition that is slowly progressive and can affect any of us at any time. So what is the cause of Parkinson's? One of the challenges of this condition is that even now in 2022, we do not know the cause. And that is why it is known and referred to as idiopathic Parkinson's disease. When you hear the word idiopathic, it's important to realize that means cause unknown. We don't know. The other fascinating thing about Parkinson's is that even in 2022, we still do not have a definitive diagnostic test. The diagnosis is based on what the doctor sees, what your history is, and how you respond to medication. While there are no definitive diagnostic tests available, people will be sent, especially by a specialist, for an MRI. And usually that MRI will come back with nothing showing. So what they're looking for there is ruling out other diagnoses. So a negative MRI is the normal result when the diagnosis of Parkinson's is being sought. So what do we think causes it? There are many theories on what may cause this condition. The most common one is that it may be environmental. We know there is a higher incidence of Parkinson's among people who have lived in the country, among farmers, among market gardeners. And indeed, the highest incidence in the world is in Orange County in America, where there is a lot of aerial spraying. So there may be an environmental factor involved with this. And when we nurses see patients, we invariably ask, what was your occupation? Did you have any exposure to chemicals and pesticides? But remember, this is only a theory. We also now know, and mainly since the late 1990s, that there is a genetic connection with Parkinson's. Some great work was done in Japan in 1998 and 1999 by Professor Mizumo, who identified several Parkinson's-related genes. And we do know there is an Italian Italian-Greek connection, which was identified in the 1970s, the Cortuzzi kindred, and they have a marked genetic predisposition to Parkinson's. So the current thinking is that if you have a genetic predisposition or a close family member who has had Parkinson's and you get hit by a trigger factor, that may be part of the development of the condition. But as I said, cause still unknown. There are other various forms of Parkinsonism, such as drug-induced Parkinsonism. And we know, and I will talk about this in another segment, that there are some medications that people with Parkinson's should not have because they may block the dopamine receptors. So drug-induced Parkinsonism we see less of nowadays, but nevertheless it still is a relevant topic to be aware of. And of course there is pugilistic Parkinsonism, and we're all familiar with people who have had head injuries. So boxers and soccer players may have a higher incidence of Parkinsonism due to repeated head blows to the head. So those are some of the theories on the cause of this idiopathic neurological condition. At the minute, a lot of research is going into some of the earlier signs, the signs that we're only aware of with hindsight. So a lot of retrospective studies have been done into early symptoms which developed before the main motor symptoms. And some of these early non-motor symptoms are really very interesting, and they're known as PARS, Parkinson's Associated Risk Syndrome. And a large study was done of people with Parkinson's who went back retrospectively and identified some of the common early non-motor symptoms. And you may, listening to this, you may be familiar with those for yourself. So one of the most common one is anosmia, which is a medical word for lack of sense of smell. And we know that approximately 90% of people with Parkinson's will have identified that they have lost their sense of smell years before their other symptoms developed. Another common early non-motor symptom is sleep disturbances. So disturbed REM sleep behavior, acting out nightmares, violent dreams, talking in your sleep. We know that those precursor the non-motor symptoms of Parkinson's. Mood changes or depression is also a common non-motor symptom that also develops many years before the motor symptoms of Parkinson's. And finally, one that you may not identify as being related to a neurological condition, but I'm sure many of you will relate to it have been a symptom of long-standing, and that's constipation. So constipation is often experienced years before the diagnosis of Parkinson's. And now that we're becoming more familiar with the pathology of Parkinson's that may precede the movement signs, all of those Parkinson's-associated risk syndromes certainly make sense. Constipation may be related to Lewy body pathology in the bowel. Loss of sense of smell was thought to be due to the fact that the environmental assaults could have a straight access to the brain through the nose. And sleep disturbance is a symptom that precedes the diagnosis and also remains problematic for the years to come. So a lot of research is now being done in early biomarkers. The Michael J. Fox Foundation are doing a huge study aimed at finding some blood biomarkers or cerebral spinal fluid biomarkers, which may help the medical profession diagnose this condition years or perhaps decades before the motor symptoms become apparent. So to recap, we don't know the cause. There are lots of theories and lots of research going in to getting an early diagnosis. One of the advantages of having a few flags that may help us with people before the movement symptoms become apparent is that these might be the ideal people on which to carry out drug trials. And in order to find something, the holy grail of Parkinson's, something that stops the progression of the condition. And that's why the research is focusing on this at the moment. So, away from theories, let's talk about what we do know about Parkinson's. And we do know, and since the early 60s, we have known that Parkinson's is related to a lack of dopamine being produced in the substantia nigra. And dopamine is a neurotransmitter that is responsible for all movement, all aspects of movement. It's also responsible for how we feel and our mood. So in order to do any repetitive learned movement, and in order for our mood to be stable and for that joy of life, we need sufficient amounts of dopamine. And for some reason, yet unknown, the cells which produce dopamine in the substantia nigra start to die off. Now you can see from the slide the white picture with the black cells going up either side. That is the substantia nigra of someone who lived life without Parkinson's. And you can see on both sides that dark shadowing of those dopamine-producing cells. The picture underneath it, that is the substantia nigra of someone who had lived with Parkinson's during life. And you can see quite clearly that the number of black cells or dopamine-producing cells are much, much lessened. If you move along to the far picture, which looks like a fetus, that is actually a slide of the brain taken at post-mortem, and that orangey fetal shaped object, that is what is known as a Lewy body. Now, the interesting thing that we've learned, stepping on from the lack of dopamine, we now know that found in the brains of people who have lived with Parkinson's are aggregations or clumps of alpha-synuclein. And alpha-synuclein is a protein that we all have in our brain, and we're really not sure what its role in our life or in our brain is, but we do know that for some reason in Parkinson's it misfolds and forms aggregates, and those aggregates are known as Lewy bodies, and that is what you're seeing in that end photograph, that part of the slide. So Lewy bodies are also found in Lewy body dementia, which is a slightly different condition. And the difference between Lewy body dementia and Parkinson's is that Lewy body dementia, the Lewy bodies are in a different distribution, and the diagnosis is made based on the differences between the two conditions. So Lewy body disease is an umbrella term which encompasses both Parkinson's and Lewy body dementia. The other latest theory is that this misforming of the protein alpha-synuclein may not originate in the brain, but it may actually start in the gut. There has been some exciting research in the last almost 10 years now, where alpha-synuclein, or Lewy bodies, were identified in the gut prior to the development of the motor symptoms of Parkinson's. So the latest theory is that the Lewy body pathology may travel up the vagus nerve and have direct access into the brain. But one of my favorite sayings with Parkinson's is, the more we learn, the less we know. So the theory, as I said, this is totally a theory at the moment, but that's a little introduction to the pathology of what is going on in the brain. And isn't it wonderful and heartening that there is so much research still going on? Because as I said, the more we learn, the less we know. So we've dealt with the theories, we've dealt with the possible causes, and now let's move on to what the doctor, and hopefully a specialist, is looking for in order to make a diagnosis. Parkinson's associations globally do recommend that you have your diagnosis made, or at least confirmed, by a neurologist or a geriatrician with an interest in Parkinson's. And the diagnosis is based on what the medical professional sees, your history, and also your response to medication when it's introduced. As I said before, there are no firm diagnostic tests, although research is working towards blood tests that may give us some definitive diagnostic tools. So what are the classic symptoms of Parkinson's? Bradykinesia. Bradykinesia simply means slowness of movement. Brady means slow, kinesia means movement. And I'm sure you are all aware, both people who are affected by the condition and particularly people living with people with the diagnosis, I'm sure you're all aware of the tendency to slow down. So slowness of movement. It may take you longer to have a shower, to walk to the car, to eat your meal. In fact, everything we do in life can slow down. So a gradual slowness of movement, bradykinesia. The second symptom that the medical profession are looking for is rigidity of muscles or muscle stiffness. And interestingly, this is a symptom that you, the person living with the condition, may not actually complain about and may not be aware of. But the examiner, the specialist or a physio or a Parkinson's nurse will be able to feel that muscle stiffness. And that is why this extension, and the doctors will put your limbs through a range of movement because they can feel that muscle rigidity. That muscle rigidity has got two names, two forms of description. The first one is cogwheel. So if the muscles are stiff and rigid and there is a tremor experienced and the tremor is superimposed on the muscle rigidity, then that is known as cogwheel. If you think about the huge wheels at the C.Y. O'Connor Museum, that ratchety movement is what the examiner may feel and be aware of, but you yourself will not be aware of it. And if there is no tremor, and it's important to realize that not everyone with Parkinson's gets tremor, so if there's no tremor, when the limb is put through that range of movement, the consultant may say, aha, lead pipe rigidity. It just feels like the resistance one would experience when working with a lead pipe. So that explains the second symptom that the health professionals are looking for in order to make a firm diagnosis. Now, the one symptom that everyone thinks of with Parkinson's, the next one is tremor. And the medical profession are gradually moving tremor down from the number one symptom to further down the list of 4. And the reason for that is, as I said previously, quite amazingly, not everyone with Parkinson's will experience tremor. In fact, 30% of people will never have a tremor. In the words of a prominent Perth neurologist, not everything that shakes is Parkinson's, and not all Parkinson's shake. So please, let's dispel that myth that you have to have a tremor to have Parkinson's. The interesting thing about tremor, if it is present in Parkinson's, is that it's usually a resting tremor. And in the beginning, in true idiopathic Parkinson's, it is usually unilateral, so one-sided. So if the symptoms are experienced on both sides, then the medical professional will be thinking perhaps this is another diagnosis. So unilateral resting tremor is a common symptom of Parkinson's. It can happen in any limb. It can happen in the upper limb, the lower limb. Tremor can even be seen in the tongue on some occasions. So tremor, it's not necessary to have it, but when it is present, it is a very easily identifiable symptom of Parkinson's. The other interesting thing about tremor is that it is the least responsive symptom to medication. So even when people go on the gold standard treatment for Parkinson's, which is levodopa, they may or may not get relief from their tremor. So as a nurse, I always advise patients of that. And I also advise people, please do not measure your condition by the amount of tremor, because tremor can be worsened by stress. Tremor could be worsened by watching the Eagles play. Tremor can be worsened by emotional problems. Tremor will always win an argument if such is going on at home. So tremor is not to be a marker of how severe your Parkinson's is. And it's important to remember it may or may not respond to medication. The fourth symptom that the doctors need to find or are looking for can happen later on in the condition, but it is commonly known as postural instability. So you may find that your gait changes, you become more forward flexed, and you may become a little bit bowed forward, and your balance may not be as good as it was. One of the tests that the doctors do will be the push-pull test, also very popular among physiotherapists. So the clinician will get behind a person with Parkinson's, take them by the shoulders, move them around, pull back and let go. But do not worry, they are always ready to catch you, because that ability to right yourself may be impaired in Parkinson's. So the general rule of thumb is that if a person coming into for a medical examination meets 2 out of 3 or 3 out of 4 of the criteria for this, then that will make the consultant say, I think you may have Parkinson's. And really, it is when a person starts on medication and their response to medication, and hopefully a positive, a good response, then that will help with a more definitive diagnosis. So While there are many, many other symptoms related to Parkinson's, and as I said earlier, it can affect all aspects of life, these are the 4 classical symptoms that the doctors have to meet in order to come up with a diagnosis. It's amazing that in 2022, the diagnosis of a neurological condition is not perhaps more scientific, but given the expertise of our neurologists and geriatricians, I would reassure people that this is built on years of skill and years of knowledge. We've talked about the 4 cardinal signs of Parkinson's, but there are many, many other symptoms which you may or may not experience. And it's really important to remember that Parkinson's is what I call a designer label condition. Everyone will have their own experience, their own symptoms, and not everyone gets everything. So the other symptoms that you may be aware of may include your handwriting getting smaller. Often that is very visible from year to year when writing Christmas cards. So micrographia, smallness of writing, may be experienced. Other things that people may experience, constipation, as I spoke about before, is often an earlier condition, an earlier symptom of the condition. Many, many other symptoms which I won't go into now. And there are many, many treatment options. My next talk, which you will be able to link in with, will be about the gold standard treatment, levodopa. But there are many, many treatment options and ways of medically managing Parkinson's in order to control the symptoms. And if you cast your mind back to my first slide when I said it was progressive, it's important to remember that when we're thinking about treatment options, because what you need today, if you're newly diagnosed, is not the medication that you're going to require in 10 or 15 years' time. This is a condition we need to always be monitoring. You need to be in touch with your specialist on a regular basis, perhaps 6 monthly, or as needed or as requested by yourself and the specialist, because we're always hoping and aiming to keep up with the progression of the condition. And also, it's time for you to take charge of your health. One of the few things we know, the only thing that we know that will stop the progression of Parkinson's is exercise. So it's never been a truer saying that if you do not use it, you will lose it. And remember, Parkinson's causes muscle stiffness and rigidity, and it can cause changes to your gait and to your balance. So exercise, exercise, exercise is the way to go. Keep moving, start walking, do high intensity training, do yoga, do anything that will improve your flexibility, improve your balance, and improve your mindset. Because we all know that exercise releases those endorphins that make us feel better, but it also will help you in your battle against Parkinson's. Many people ask about diet, and while there is no formal recommended diet for Parkinson's, the main thinking at the moment is a good Mediterranean diet. So lots of fresh vegetables, lots of antioxidants, lots of fish. The diet any of us should be having, but particularly with fruit and vegetables for the management of constipation. So diet is really, really important. Also, if you are listening to this and you are relatively newly diagnosed, I would recommend that you explore the allied health options that are available to you. I personally believe it's never too early to introduce physiotherapy and occupational therapy into your supportive team. Speech therapy is a great ally to have with you in order to overcome that tendency to a quiet voice. So it's important to have some upskilling by the allied health relevant to their field. So a speech pathologist will instruct people in the management of that quiet microphonic voice. So the key thing is think loud or speak with intent. But allied health input across the gamut for balance, for posture, for writing, for equipment, for swallowing, and for speech is essential. As I said earlier, one of the early Parkinson's-associated risk syndrome symptoms may be apathy, depression, or a change in mood. And we know this is related to the lack of dopamine. The change in mood or the potential for depression is not simply because you've been given this diagnosis of a neurological condition, but it happens way before you're given that diagnosis. We know dopamine is the neurotransmitter that you get a rush off when you fall in love. So think back to how good you felt then, and then you can relate to why you're feeling a bit flat because of the lack of dopamine. So it's important to try and fill your life with positivity, try and maintain contact with friends, with workmates, and do not become a recluse and do not ponder too much on this condition unless it is pondering to plan your treatment and your own interventions. A little word of warning or one of my battle cries when I'm talking to people with Parkinson's, especially in the beginning of your journey. If you've been started on medication and you're feeling amazingly well and you're feeling much better and you're wondering what was all the fuss about for the last year, remember that is the action of dopamine. And dopamine is a feel-good neurotransmitter, and we're trying to replace it. So I would ask you to respect your medications. Always follow your consultant's guidelines. And while there may be a tendency to try to self-medicate or self-prescribe, please try and resist that temptation, because we want you to respect your medication and remember that we need to have something in the medicine chest for later on, because in an ideal world, or in the world that we live in with Parkinson's, this is a long-term condition. So respect your medications, take what you're prescribed at the times you're prescribed, and you will enjoy your journey with Parkinson's, if possible, a little bit easier. So I think that brings to an end this introduction to Parkinson's, which, as you can see, was a very general talk. Hopefully it's answered some questions, and hopefully you will link in for the next short seminar that I'm hoping to do on levodopa, the medication primarily used for the treatment of Parkinson's. Thank you. Thank you for your time.